Welcome to the process. It's me, Sterile MD, and Alessandra Nicholson. We're
Very good.
we're here with Leslie Kronstedt, and we'll be talking about healthcare finance. We will be right. Hey guys, welcome to the show. It's another wonderful Wednesday, and we have some nice little platform here. Hope you guys like it. We're trying some new things. We're trying some new things, and we're trying to bring Leslie Kronstedt on to give you some info on healthcare finance. Alessandra Nicholson, how are you doing today?
I am doing great today. I am in Illinois today and it is very hot.
Tell them a little bit because I don't want to give too much away as to what
Yes.
Leslie is gonna be doing
Right.
or saying.
So if you guys have watched the show for a while, you have probably seen Leslie Kronstedt in the comments. She is a very big fan of the process. And we had her on to talk about a clubhouse presentation that she gave on finances and how they impact surgical services. So I had an opportunity to sit down and ask her a million questions about finance, how revenue cycles work, how the money moves within surgical services. So we'll get to watch some of that interview today, and then Dee and I will also have some discussion around the topics and make sure that we're answering any questions that pertain specifically to SPD.
So Alessandra, I know you had a good conversation with Leslie. How much does the financial situation affect us right now in terms of our policies and how much we pay for insurance right now? For
Well, I think
when I
it
work
affects
on
us
things.
all greatly, right? We all remember what it was like when the Affordable Care Act was being discussed and then finally passed, and now we've seen it offer health care to millions of Americans that were not previously eligible for private medical insurance or just didn't have it through their employers. So it makes a big difference. And then seeing the changes that have come about through the ACA, like the EMRs really taking off, like surgery, moving from a fee for service, which, if you guys aren't familiar, Leslie tried to break that down a little bit and just saying fee for service was the previous model in which you would get an itemized bill for everything that you had done to you at that facility, and that would include the products that you used as well. So, especially for those of us in the SPD world that came from materials management, or if you're still in a department that's both, that's dual, then you know what I'm talking about. Or if you pull case cards, you know what I'm talking about, where there's multiple products that are going to be pulled for any individual case. And whether they were used or not used, patients were being billed for them. And what they found, what Leslie was explaining to me, is that they found that just like any other business, hospitals were marking up the services um, through that process. And so bringing in this value based reimbursement changed everything because they got one fee for the procedure. It includes everything. So that if you're having surgery, that value based system says that your surgeon, your circulating nurse, SPD, all your materials, all your pre and post care, one fee, and the hospital needs to either meet it or beat it. They either need to make sure that they don't cost more than that because they will not get more than that, or they can do like any good business and come under budget. If they come under budget, they get to pocket the cash. And so that's where their profit, some of their profit, comes from.
And also check out the YouTube channel, Sterile MD on YouTube. Please give a like and subscribe and hit that bell notification so anytime we have a new show or new video coming on, you get that notification. So without any further ado, here is Leslie Kronstedt. How are you doing, Leslie?
I'm doing good. Oh boy.
Hi, Leslie.
Oh, hello. How's it going?
Good, good. How are you?
Good. All right. I figured it out.
I just dropped the link for the hospital compare in the comments. And if you guys take a look at that, essentially you can type in your zip code and your facility name and take a look at how it stacks up against the other hospitals in your area.
All right. So, let's see. Let me go ahead and pull up my stuff here so I can. You guys are doing great. Like, I feel like I don't even need to come on here. You guys learned so much from me already.
It felt like a big test. I'm like, okay, what do I remember? Because this was such a long. We talked for hours on Sundays, guys, about the financial impacts to surgical services based on the ACA and all of these changes that have happened with billing, fee for service, the integrated delivery models. I did a deep dive into Leslie's brain. It was a lot of fun.
Yeah.
Because
Alright.
Leslie, you actually have a background in financial services, right?
Yes. Yes, I do. So I have a bachelor's degree in healthcare business management. And with that, I learned a lot of the administrative approach to healthcare. And then I fell into CS. So I have both the clinical side as well as the administrative side that works really well for me. So I have a really unique perspective because a lot of people, there's just this huge gap between the administrative side and the clinical side. And I am working towards bridging that gap to make it so everybody kind of understands each other a little better. That's really my biggest pet peeve right now, is just to close that gap. Well, or like crevice.
Right. More like a giant crater in our healthcare services. One of the questions that Denard asked me was, how do you feel like this impacts the cost of insurance for patients? Is this something that they should be paying attention to?
It does impact the cost for patients. A lot of times you're going to end up seeing the bill when it comes through for Medicare patients primarily. It's going to be a lot less than it was before, because they're taking a huge unknown of how much it could have cost for surgery, and they're making it as like, okay, it's definitely going to be this much money, so you're going to have this much out of pocket, and they're kind of eliminating a lot of those unknowns. As a consumer of healthcare, it's really important to know what you're paying.
True.
So,
and this is like becoming such a big conversation, especially now where patients are getting like third-party bills and not necessarily knowing upfront how much it was going to cost them.
Yeah, exactly. So it's kind of eliminating that question mark of like, what am I getting into? How much am I going to owe? A lot of people, especially on Medicare, they live on fixed income, so it's really important to them to know exactly what they're going to be, how much they're going to owe.
Yeah. I'm so glad you said that, because it's something I think not a lot of us think about unless we're dealing with folks that are on Medicare to Medicare. But yeah, usually they are on a fixed income. So them being able to know upfront absolutely exactly how much it's going to cost is extremely important. They're not going to be able to pull that money from anywhere else.
Exactly. So if you want, I'll go through and I'll do my presentation for you.
Yes, please, ma'am.
Well, we got through until we started talking about the revenue cycle. So we talked about the ACA. We got to watch you present about fee-for-service versus value-based reimbursement. Okay. And then we got to learn a little bit about the integrated delivery systems. And that's kind of where we stopped.
Okay.
So we're going to, Leslie, hold up. We'll go to a 30-second break and we'll be right back. So just get your stuff together. And sure. Guys, thank you for staying on. We'll be right back in a few. Thanks, guys. Guys, welcome to the Process Show. Leslie will give us a little presentation on um, her healthcare financing presentation a little bit because we went through a little some of it earlier, but we had to stop because we had a couple issues. But Leslie is here live to help us out and give us a little more information or a lot more information on where the healthcare system is going right now.
Yes, and how those
So
fees work when we talked about the physician fees versus facilities.
Okay, so you're down at physician fees.
Yes.
yes, ma'am.
Okay. All right. So we talked about the revenue cycle and how everything is how that works, and it breaks down into payments and it gets sent out to insurance. Well, when it's billed, it's separated into physician fees and facility fees. So let's talk a little bit about physician fees. So payment, think of it this way: the payment is made up of a person's wages and salaries, any work-related bonus, or anything else that affects income. So not everyone is created equal in the wage department. Wages and salaries are influenced by training, education, and skill levels. Think of it as the employer's wants and needs also. They hire someone based on availability, negotiation comes into play. The same can be said for how insurance and payers make payment for services rendered to those physicians. For physician fees, they are paid based on a number of factors. Many methodologies are used to pay physicians. These payment methods differ based on numerous factors or combined factors, such as the type of health plan or the insurance, benefits design, geographic location, physician specialty, the physician's organization structure, whether they're part of a affordable care organization or not, negotiating strength of either group, and then finally you have state and federal laws that come into play as well. So the insurance medical policies, for example, for who's in attendance for a procedure will affect payment. So if a second surgeon is in attendance, then that surgeon is paid half the price of the primary surgeon. And multiple players, such as primary, secondary, and tertiary insurance, and they could have competing payment methods. So in short, it's nearly impossible to know exactly how much physicians are paid by any one payer. There's also risk-based and non-risk-based physician payment methodologies. So risk-based are generally confined to health maintenance organizations, or the HMOs, meaning that the physician's financial outcome is tied to the financial goals of the payer. So if the physician is helping to control costs, the HMO's total cost of services. Historically, they found that this causes the cost for insurance to be lower. But even with that, most provider payments continue to be non-risk based. So how in the heck do you know what you're paying your doctor? They use a fee schedule to determine the basic cost of services rendered prior to insurance charges. So that's so it's really just confusing. So
And how does that fee schedule compare to the charge master?
yeah, the charge master is so the charge master is for facility fees only. So the fee schedule will look at just the physician base rates, and then the charge master is for your facility fees. So the hospital charge master is based where the facility charges begin. Um, it's a list of all the billable services and items that a patient or insurance payer would end up paying. The charge master captures and the costs of each procedure, service, supply, prescription drug, and diagnostic test provided at the hospital or ambulatory facility, as well as any fees associated with services, such as equipment fees and room charges. So the hospital's charge masters are updated yearly. Maintenance can be especially challenging as public and private payers continuously update and change coding and reimbursement rules. So the Center for Medicare Services updates Medicare's prospective payment systems every year, and that can modify the systems as well. So additionally, the medical facility is responsible for updating their charge master to reflect their operating costs, such as the clinical and non-clinical employee wages, building maintenance, the building leasing, maintaining information technology, and other additional expenses. So when a private payer, so say if you go in and you don't have insurance, they would follow, they would end up paying whatever the charge master says
Okay.
is the cost for care. A lot of times, if you are a they call like a cash and carry patient, where you don't have insurance, you're paying cash for your services, they'll give you a discount off of the charge master.
Hmm. And
Otherwise,
how would a patient navigate that? If I come in and I want to pay cash, where do I go to talk to someone about potentially
a lot
reducing
of
my
times
cost?
if you go in, you can go to the business office
Hmm.
and you can ask them, like when you go into the reception desk, ask them and say, hey, I need to talk to somebody that's able to accept cash and for my payments and stuff. And they'll direct you to someone. With everything with COVID right now, everything is remote. So a lot of those people are still at home.
Indeed, indeed, and
But
that's
they will
tough.
get your numbers and they'll call you back and they'll set something up for you.
Absolutely.
But they do estimates too. So I know the charge master should be getting easier. The price transparency rule was enacted by CMS in November of 2019 um, regarding those charge masters. So the policy led the Foundation for Consumers of Healthcare to know the basic costs of hospital and ambulatory surgery services before receiving care. This gives the patient the option to shop for the best price. So that rule actually came into effect on January 1st of 2021.
Mm.
So each hospital operating in the United States is now required to provide a clear, accessible price information online about items and services they provide. So prior to this, the charge master for each medical facility was not accessible to the public. It was like a big bad secret.
Mm.
So um, now it's out and it's available for anybody to look at. Um, Unfortunately, what you're going to find is going to really vary because in the last year we were dealing with COVID. So a lot of the hospitals, this law, this rule went into effect in 2019 at the very end of it, and that's right when COVID was starting to take off. So the hospitals were just nailed with COVID. They weren't prepared to take on this price transparency rule that took effect this year. So when you go and look at those charge masters, they are just kind of all over the place. Some of
Mm-hmm.
them are extremely well done, and you can look in there and see exactly what you want, and you can search for it really easy. And other ones are just spreadsheets with thousands and thousands and thousands of, uh, you know,
Mm.
different prices,
Just this
and you're scrolling,
convoluted
scrolling,
list.
scrolling. Like I don't know what I'm looking at.
Lord.
But a 2013 study conducted by Johns Hopkins University found that prior to the hospital transparency rule, the average hospital with over 50 beds had a charge to cost ratio of 4.32%, meaning that the hospitals charged $432 when the beds actually cost about $100 to give out to a patient. So the
Blown
study
away.
concluded that medical facilities apparently marked up higher prices in departments with more complex services because it's more difficult for patients to compare prices in these departments. The hospital price transparency rule would reduce price gouging further. So hospitals that fail to comply are charged $300 per day for noncompliance.
Wild. Wild. So definitely in the beginning we just kept saying it's a business. It's a business. It's a business, right? So
Yes.
from a business standpoint, it's not shocking to me that someone would mark up the cost, the foundational cost of their service 4.32%. But then on the flip side, when I hear that a hospital is charging $432 for a service that costs $100, I'm outraged.
Yeah.
It's wild. And so and especially just I keep coming to this fact that you had about 53% of our surgical procedures are being performed on patients over 65 years old. So more than likely being performed on patients with Medicaid, Medicare, which you also mentioned, more than likely means you're talking about folks on fixed income. And then I find out that you charge a Nana 4.32% more than what it actually costs.
Yeah.
It's
Yeah.
just debilitating. And then so
Yeah.
we talked a lot about the global billing and how that worked. But could you talk to us a little more in depth about the post operative days and how that's navigated?
Sure. So a procedure is delegated into three categories of global billing, surgical billing. So either 0 days, 10 days, or 90 days within the global surgical package. So endoscopies and minor procedures would have no reason for a follow-up with the patient is generally given a 0-day global package. So that doesn't mean that they're not going to follow up with you. They might give you a phone call and say, "Hey, how are you feeling? You know, is your surgical site feeling okay?" But that's not part of the overall billing structure. That's just them being nice and calling and making sure you're okay. So 10-day post-operative period would be minor surgeries. And then you have 90-day post-operative periods, which are considered major procedures. So the zero global billing has no preoperative period. They just count the day of surgery and that's it. The 10-day global billing has no preoperative care. So it's the day of surgery and then 10 days after that. And then 90 days includes a preoperative visit after the decision to operate has been made. So that includes like any preoperative visits that's needed. You have your day of surgery, and then post-operative care includes follow-up visits and care that relates to the surgery that was performed. There are exclusions of care that occur that is unrelated to the purpose of the surgery that occurs naturally that would be billed separately. So if you come in for a total knee and you're sitting in your patient's in your room and all of a sudden your appendix bursts, that would be a totally natural event, and we would bill that separately. So that would be two separate billing things. And then
No two
that
for
would
one
probably
surgeries.
be
No
so
two for the price of one surgeries. Okay.
yeah, no. Um, so what does the surgical package all include for the facility? So this is going to include everything from the cost of the implant device to the cost of the surgeon, assistants, all staff, anesthesia service, and even the physical therapy providers is included in this. The cost for surgical supplies, durable medical equipment, the overhead expenses are all included in the bundled payment, global payment. When the cost of the surgery under the total cost of the insurance is paid, then that's where money's made. So if you have a surgery that costs $5,000 and they say, okay, we feel that we can get this surgery done for like maybe $3,000. The insurance says we'll pay $5,000. And then as long as you don't go over that and you can maintain underneath of that, so if they actually keep that $3,000 at the price point that they said that they could, that's $2,000 in their pockets and money they made. If on the flip side they had complications or something comes up that they didn't anticipate, and they go and they have a $10,000 surgery, that extra $5,000 that was not pre-planned out and approved by insurance they have to eat that.
Now, Leslie, let me ask you, what do you think the incentive is for CMS to allow the hospital to keep anything over what they originally billed?
So yeah, so if they can keep the cost of surgery underneath of that, it's incentivizing them to reduce their costs, to be more proactive, make sure that their teams are not using more items than what they needed. There's lots of different ways that they can really reduce the cost, but it just comes down to teamwork and communication to make sure that they are staying within their goals and utilizing, the data and the data, the patient electronic medical records to kind of estimate, is this patient high risk, and taking all that into account. So they have the tools, they just have to utilize them.
They have the tools, they just have to utilize them. So, before we go into talking about how the healthcare acquired infections can impact those and talking about penalties, we're going to take a quick break.
Sure.
Hey guys,
Welcome
I'm back.
back.
You know what they say, high risk, high reward. So this is definitely gonna pay off. Thank you, Leslie, for coming on. Appreciate it. I'm gonna put you back down in the middle. So, okay, but Leslie, I want to address. I listened to you a few minutes ago. I heard. I don't know if we spoke about this on the walk. Um, I'm not sure how true this is. Based on like you're talking about laparoscopic surgery, based on if there's a polyp um going in for a biopsy, if you find the polyp, it costs more, or if you don't find the polyp, it costs less, or something like that to that extent. What were we talking
Ooh.
about?
So this was in reference to endoscopy procedures.
Okay.
You remember this?
I did not remember this, but
Yeah, so this came up in a process walk. See, that's why y'all need to be there on Saturdays,
Yep. Yep.
mhm.
8:30 a.m. But this came up in a process walk essentially about potential fraud in the ASCs. And definitely, alleged.
Alleged, 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 alleged. Should I put my disclaimer up
Allegedly.
here? I'll get the disclaimer up here real quick.
Look, we had heard, no,
Yeah.
but essentially just kind of hearing on the street that physicians within some of the ASC models had kind of figured out how to rig this system. And what they found was that they could increase the reimbursement for their endoscopy procedure if a complication was found within that procedure. And so they were just discussing their experience of there being some fudging, if you will, on the
Mhm.
medical records to increase those reimbursements. And so it's something to think about. I mean, definitely as we're talking about everything kind of, or the list of inpatient procedures being phased out and the list of ASC eligible procedures going up, that's a concern, right? If are we going to get the same standard of care? I know one of the things we talked about was that orthopedics is saying that we will see a 60% drop in costs associated with the ASCs. But do we see an increase in good outcomes within the ASC service line?
Um, the thing is with the ASCs is that they choose to they choose patients for the ASC based on their risks. There's a fancy word for it, but I'm not even going to try it because I was trying to butcher it. Um, but there are risks, so they have different risks, and a, a doctor has to make that decision of whether they're a good candidate for the ASC or not. When you
Mm.
have something where somebody can go in and fudge the electronic medical records like that and change, like, oh, we have a polyp, oh, we found this, and that's generally going to happen in that would be more likely to happen in your private insurance,
Mm.
because with
Hmm.
Medicare, they have it set where no matter what happens, if all of a sudden, like, your patient is, they go in for a lab and they end up having to open them up, it's all going to be one global price. So it kind of goes back to that all-inclusive
Method of
resort.
global
So
billing,
you
right?
went in, you were only thinking one or two margaritas, and you decided to go all blitz out. So, like, it's okay. We're still going to charge you that one fee. But when
There
you
you
get to
go.
those private insurances, that's where the problems come in at.
Can definitely have
Hmm.
some opportunities for risk there, right? And
Yeah.
one of the things that Dee and I talked about earlier was just incorrect billing, right?
Mm-hmm.
Potentially overcharging patients for services that they may or may not have received, and or for the hospital leaving money on the table and not properly documenting the type of care that they gave.
Yeah, and that's where, like, a lot of it now is our electronic medical records. The insurance companies are taking those from us and they're looking through it. They have nurses and stuff in their offices and they're going through those records and seeing if they make sense. Do
That's
these
true.
add up? Does this make sense? And it's happening on the hospital side too, where there's multiple layers of people that are going through and they're saying, okay, like, is this normal for a procedure? Is this something that we have to go and check back with the people? Like, even
Mm.
when, when I went in for my first surgery to go just observe it, they were like, what's your name? Who are
Hmm.
you from? Where are you from? What's your number? And they put that in there because it's got to be in the electronic medical record that you were there in the room at the time of that
Oh
procedure.
wow.
So every little detail is in there. So if you walk into that room, they're like, okay, who are you? We need to have you on the record that you were here, because if something should happen, it would need to go to legislation or something and go to court. They could potentially pull you in, and they need that information.
Absolutely, right. We talk a lot about that a lot within sterile processing. That those are legal documents. When you
They
complete
are.
things like your sterilization records and your cleaning logs, all of that becomes legal documents because they could potentially be pulled to discuss the care that was provided to a patient.
Yeah, and insurance fraud is like no, it's yeah, that's bad. You don't want
Wouldn't want to be ya.
to. Yeah,
Wouldn't
there
want
are
to be ya.
severe penalties for that. Really severe penalties, including up to prison time and everything.
Absolutely, absolutely. So, Leslie, I tried to give a little bit of an explanation of the percentage drops that a facility may face if they find that the readmission rate is very high, or some of these procedures that they're monitoring for are coming back with high numbers. But you are the subject matter expert, so could you break it down for our audience listening? If I have a procedure and it's within that global billing time span, and I have a complication, what can my facility expect as a repercussion?
Okay, so when things go wrong, that small margin of profit that we were talking about for surgery, that makes it profitable, diminishes. So
Mm.
let's talk about the healthcare acquired infections in medical facilities. Back in 2005, the Deficit Reduction Act encouraged the Center for Medicare Services to find a solution to never events and hospital inquiries, but in, inquired infections. But it wasn't actually until 2008 that the Inpatient Reduction Act was passed and introduced the Healthcare Acquired Conditions Reduction Program, which encouraged hospitals to improve patient safety and implement best practices to reduce the rates of infections associated with healthcare. But just because that was passed doesn't mean that they were actually at a point where they were getting reimbursement docked.
Mm.
It wasn't until 2014 that they had originally 10 categories of conditions for add-on payment elimination for avoidable conditions, and then in 2013 it went up to 4 additional categories for a total of 14 total conditions that they watch for.
Mm.
Um, so then, so when this program moved to the point where it was launched, where it impacted the payments of the healthcare systems, it evaluated hospitals based on their rates and several avoidable complications, which were like bed sores, blood clots, central line infections, falls, surgical site infections, infections from like MRSA and C. diff.
Mhm.
And then since 2016, that national action plan that is developed, and it changes each calendar year. You're going to see it doesn't really change too much. It's kind of the same issues over and over. So each year, the bottom 25% of all medical facilities across the United States with the worst healthcare acquired conditions are subject to a 1% payment reduction on their overall Medicare payments for the entire fiscal year. Additionally, each medical facility is subject to the Center for Medicare Services public reporting of healthcare acquired conditions reduction program results, and that's put onto the CMS Hospital Compare website. So you can see how your facility is rated above, below the benchmarks compared to every other hospital throughout the country on their healthcare acquired conditions reporting parameters, among others. There is one outlier, and I believe it's Maryland, that for whatever reason, they are not part of the program. Don't ask me why.
Okay,
I have
Marilyn.
not been able to figure out why. Um, but they seem to
What's
have
going
this like
on?
goal of like, we don't know what's going on in Maryland. So
All right, all right.
so that's the only state that so far you cannot see what the parameters are. But every other state, it's all out there for anybody to see. So as a consumer, it gives you the power to determine if you want to be treated at a specific hospital compared to another one. The CMS Hospital Compare gives you data from everything from pneumonia rates to heart attacks, to central line infections, to surgical site infections, to a few different types of common surgeries that are performed at the hospital. So you can kind of take a look at it and say, okay, this hospital, they really are not very good at pneumonia treatment, but this hospital over here is, but this one at here that's good at pneumonia, they don't do very good at hearts. So I wouldn't go there for hearts. And that was kind of what I did when I had to take my grandmother in for procedures. I went onto the hospital compare website and was like, okay, which one's really good at what? So as a consumer, that's something that you can use and utilize. And then the other part of this would be the readmission penalties. So with the passage of the Affordable Care Act, it was introduced with the Hospital Readmissions Reduction Program, which is a Medicare value-based program. So it was rolled out in 2013 with the intention to improve communication and coordinated care to reduce avoidable remissions. So data is collected based on 6 conditions or procedures within 30 days of discharge. And the Center for Medicare Services calculates the facility's performance and gives a 1% reduction on their overall Medicare payments for an entire fiscal year. And then it goes on a 3-year rolling performance period. So if you do bad 1 year, it's 1%. But if you do bad the second year, you can get nailed for 2%. If you do bad a third year, you can go up to 3% total reduction in your Medicare payments. And these payments can be combined with other programs such as the Healthcare Acquired Condition Reduction Program, compounding the Medicare payment reduction for the entire fiscal year up to 4%. So when you have 53% of your surgical volume are over 65 and they're probably on Medicare, that's a huge chunk of your, entire population there that could potentially, you're losing 4% of your entire reimbursement for. So that doesn't sound like a whole lot, but when you're looking at 53% of all your surgical volume, that's a huge number that you're losing money on.
Huge. And it's also not like you're able to make it in other places, right? So you just lost that money. That's it.
Yeah, you just lost it. It's gone, and there's no way to get it back. You have to wait for the time to go on, and as a sterile processing technician and as a surgical technician, you can do things to help your facility manage those. You can help in that. So I know when I go and I look at facilities as a place that I would want to work at, I could look at the hospital compare website and say, well, what is their hospital acquired infections rate at? It could give you an indicator of how that CS could possibly be running and that OR is running.
Right. So I did a quick search on the hospital compare for the region that I grew up in, and all 4 of our major hospitals are 2-star systems. Wouldn't have ever guessed that from the outside.
Yeah. So it's it's definitely something that you want to think about as an employee of the hospital, is that your work performance is literally out there for the public to see.
Right.
It's something, you're working in the basement and you don't think about it. You're always like, nobody knows me. They don't recognize me and what I do. But when that hospital compare website pops up and they're like, oh, we've got a lot of these hospital-acquired infections, all of a sudden they're like, hey, we don't know who you are or what you do, but we know that whatever it is has an impact.
It's affecting the bottom line.
Yep. So, and then, yeah, it's just crazy.
So Leslie, what's the determining factor for choosing a facility? Okay, let's say the infection rate is high, but the cardiac, the open heart cases are 90% successful. So how do you choose? Do I go there? Am I getting an infection, but the rates of success are high? So how do you choose which facility to go to in terms of that?
You want to take into consideration that when they're recording the surgical success rate, it's taking into effect if somebody is getting a surgical site infection too.
Mm. So
So
not
if they have a
including.
really good report for their cardiac surgeries, I would feel comfortable going there because it looks at the full length of the procedure and that post time for the 90 days of whether that patient developed a surgical site infection or not.
Hmm. So much to think about, especially as a consumer. I mean, I think we take it for granted working inside the system, and it's complicated for us navigating, but for the patient to have to find these websites, look at the different procedures, look at the different costs, the different charge masters, and when really people just want to say, okay, I don't feel good, I'm going to the doctor. you know,
Yeah.
True.
Keeping it simple.
True.
So Leslie, the last question I want to ask you, and it's a question that we talked about a little early on. Why should the SPD tech pay attention to this? Why should the folks working in surgical services pay attention to this?
This is really important because when you want a new washer, you want higher wages, whatever it is that you need within your department. You have to take that to your C-suite, to your administration, and they're the ones that are holding the purse strings. So you have to be able to talk to them in a way that they understand. And when you have this information, all the laws and all these different aspects of care that they are concerned about, and if you can talk to them using that information, like, okay, if we have a new washer, we would be able to prevent healthcare acquired infections because, not having a good washer, we're cutting corners that we shouldn't be. So let's do it this way. Let's get this new washer. We can potentially reduce readmission rates because of this. Or, whenever you have that information and you're talking to them from that perspective, they're like, oh, sting, got it.
Right.
Like, yes, we want to reduce readmission rates. Yes, we want to reduce healthcare acquired infections. So,
Right. Like
like,
they
what
may not know every little thing about SPD, but they know that.
they do know that, yeah. So that's the stuff that they do recognize. So you have to come at them from a perspective that they understand. And if you can talk their language, which is what I've kind of tried to put out there, is this is their perspective. This is what they see. This is their knowledge. And once you have that insight and you say, okay, I understand that you are worried about the revenue cycle and integrated care, and you've got all these different aspects of methodology to make sure that we get paid, but I want to make sure that we get paid too. So, let me talk to you about these laws that I know will affect our reimbursement.
Yes.
Let me talk to you about we need another sterilizer or we need more equipment because we don't want to be flashing the stuff. We don't want to have the patient on the table because every minute that the patient's on the table, that's adding money onto the case that potentially won't be reimbursed.
Correct.
So,
And I think
um,
one of the things that I'd like to I don't know if maybe Leslie can come back or maybe we could try another recording, but I think one of the things I'm interested in is, are there tools that we can give to the technicians that they could do this, or to the managers and they could do this? Like maybe we can look at staffing matrices, or maybe we can look at
Mm-hmm.
how you can evaluate your product costs, or whether or not you even have a clear idea of how much it costs you as an SPD department to produce a pack. I'm seeing more departments start to pay attention to that, of how much is the cost of the salary, the integrator, the wrap, the steam, and do we actually know that when that surgeon asks us for a kit, this is the average price?
Absolutely. Yeah, it makes a huge difference to know that stuff because, as SPD has always been like, well, they don't make any money. And it's like, no, wait a minute. We make money. We have a service, and
Yes.
in that charge master, somewhere in there, that's the cost for your employees, that's the cost for your steam, that's the cost for the water, that's the cost for your equipment, there's the cost for all this stuff. So we are, we're saving them money from
Yes.
having to have all these disposable items.
Right.
And, so
Which is such an interesting conversation because you're seeing such a push to go disposable in certain things. But
yeah,
yeah, like us being able to reprocess equipment saves So much money.
It saves money, especially when you think of how much time goes into, there's, you have your flat fee for your instruments, but when you're going through and they can be used hundreds of thousands of times if they're taken care of properly, which is a whole nother thing to talk about.
Right, a whole nother show.
Yeah.
Absolutely, because I've had a rep that went to the kitchen and came in with a spoon and was like, "This
Girl.
kitchen needs a spoon," and I was like, "Yeah, not that kind of spoon, buddy.
Not that kind of spoon.
An IFU."
Right, we
Yep.
only take the ones with an IFU. I know it looks identical, but
Right.
no.
Right. Definitely.
So,
Leslie, thank you so much.
yeah, hopefully in the future I'll have some more stuff, and I'm preparing stuff right now to be able to
Yes, y'all
guys.
watch out for Leslie Kronstedt. The girl is on fire right now.
Yes.
I've been watching your posts on LinkedIn, and it's just so much good stuff and conversations that we get so hyper focused on cleaning and reprocessing and the new IFU and the new Amy standard that we forget about the technician. And so it's been really refreshing to see some of your content on LinkedIn.
Yeah, definitely. Right now I'm working on legislation for certification and how all that's kind of coming into play, because we hear about it, but does anybody really know about the whole steps in the government process and why it's taking years to get certification in certain of these states? So I think that's something that we should really take a deeper dive into and see. So that's coming up in the future. I'll have that for you guys.
Excited to hear.
Very, very interesting. I have no bombs today. I would have dropped a bomb on that one, but
New platform.
this is one of the only shows you'll not get a bomb on, guys. So savor it now. But definitely, Leslie, thank you. Alessandra, thank you for hanging in there. Thank you for watching. We'll see you in the next one. Peace.